My name is Kevin Billingsley. I have the pleasure of serving as the Chief Medical Officer of the Smilow Cancer Hospital and the Yale Cancer Center. And on behalf of my partner, Kim Slusser, and all of us here at Smilow and the Cancer Center, I'd like to welcome you to this patient and family forum that is focusing on COVID-19 vaccinations. I want to take a minute to just update people on the program and introduce our panelists. Kim and I will be going through some brief clinical updates, and then we're really going to jump right into the main body of our program. And our aim this evening is to update our audience, you, our community, on key developments in the rollout of the COVID-19 vaccination, both within our healthcare system and across Connecticut, and answer any questions and concerns related to the unique challenges that our patients face as we navigate through this ongoing pandemic and we all move towards the safety of being vaccinated. So I'm really delighted to have an outstanding panel of people who are contributing this evening. I first want to introduce Dr. Kerin Adelson. Kerin is a Deputy Chief Medical Officer. She's a breast medical oncologist, and she also serves our system as our Chief Quality Officer. Dr. Tara Sanft is also a breast medical oncologist by clinical practice, but she importantly serves all of our patients and families as our Chief Patient Experience Officer. I think I briefly introduced my partner, Kim Slusser. Kim is really our Chief Nursing Officer, and she's our Vice President of Patient Services. It's a pleasure for me also to introduce Dr. Stuart Seropian. Dr. Seropian is a professor of medicine, and he's director of our stem cell transplant program and co-director of our CAR-T program, and has many other titles and accolades related to his service to heme malignancies patients and BMT patients. At some point during our presentation, we are likely also going to be joined by Dr. Tom Balsazak, who is the Yale New Haven Health System Chief Clinical Officer. So with those introductions out of the way, let me just kind of go ahead and inform our audience of a number of kind of key developments in our program. I think it is really important to take a minute to acknowledge what we have all been through over the past year. It's almost a year to the date when our world changed in a very profound and traumatic way. It was about this time that the very first patients were being diagnosed with COVID-19 here in Connecticut, and we started to see patients coming into the hospital. This led to some very rapid changes in the way we provided cancer care to our patients and our families. We shifted very quickly to many of our visits as virtual, and we have adopted telemedicine, telehealth as one of our central pillars of clinical care. And we had to, in a very short period of time, relocate a number of our inpatients out of the Smilow hospital building to other sites of cancer care delivery here in New Haven. And it also required us to shift many of our ambulatory operations out of New Haven. Fortunately, in the months that have followed, we have been able to resume the vast majority of our normal operations, with the exception of one floor here, or actually 2 floors here in the Smilow Pavilion, and many of our ambulatory operations are back in our normal positions. However, we continue to work within an altered environment. We continue to care for a large number of COVID patients here in New Haven and across our healthcare system, and this has required ongoing adaptations to how we provide care and do business. Fortunately, we are moving in a slow but steady way back to very normal operations, and the rollout of this vaccination brings great hope for all of us. You'll hear more about that as we move along. One of the updates unrelated to COVID, but I think it is important for me to share with our Smilow community, is that our leader of the Cancer Center and the Cancer Hospital for many years, Dr. Charlie Fuchs, is not on the call this evening. Dr. Fuchs has, as many of you know, taken a position with Genentech Roche, and he's gone on and left our organization to become the head of global drug development in that very important industry partner for us. We miss Charlie terribly. Many of us, he had a profound impact on many of us. He, I think, elevated care to a new level and recruited many of our key leaders. And I will assure all of our community that the very important clinical initiatives that he spearheaded and started will continue in his absence. And Dr. Nita Ahuja, who is the chair of the Department of Surgery, has graciously stepped in an interim role as Cancer Center Director. Dr. Ahuja could not be with us this evening, but I am absolutely confident that all of our key initiatives in our care signature will continue. Lori Pickens, who is our Senior VP of Cancer Care Services, also continues in her role, and many of our key leaders are here to ensure that we have uninterrupted service. So with those quick updates, Kim, let me just turn it over to you. I know you have a number of things to share with our community as well.
Thank you, Kevin, and thank you everyone for joining us this evening. I think, as you can see from my background, our health system has been celebrating a week of gratitude across our whole entire organization. We have been taking time to purposefully engage with one another, to acknowledge our blessings, share appreciation for getting through the hardships, personally and professionally, that we have experienced throughout the pandemic. As Kevin mentioned, we are really literally this week, 1 year in to this pandemic. And we have been using this time to create space for all of us to cherish the moment and show our gratitude to one another. It just seems so timely that this evening we're having this forum, and I thought it would be a great opportunity for, on behalf of Smilow, to thank you for entrusting us with your care throughout this year. Our patients and their loved ones inspire us every day, and we feel honored to be able to do the work we do. You really, truly inspire us to be our best selves. There are a few updates I wanted to share this evening. As vaccination efforts continue and we experience a steady decrease in our COVID hospitalized patients, we have expanded our visitation for adult inpatient for adult inpatients, and we are now allowing one visitor for patients that have a length of stay of greater than 8 days. We know it has been very, very difficult throughout this pandemic to not be with loved ones when you have to be hospitalized. So this is our first step to start to allow visitation. Of course, we continue with our other exceptions, allowing visitors for when a patient is ready for discharge and there are some complex discharge needs. A visitor can, or a support person can, come in close to that discharge date to hear those instructions with their loved ones and make sure that all questions are answered. We also allow visitation for anyone with any type of disability requiring their support person to be with them to make sure that their needs are met. And also, unfortunately, some of our patients do experience the end of their life during their hospitalization, and we want family members to be with them at that time as well. As far as our ambulatory visitation, we are still trying to limit visitors, just trying to continue to keep that social distancing and keeping our patients and our staff safe. But I want to remind our community that we are allowing a support person to be with our patients during that first initial visit to one of our doctors and with one of our care centers. We also allow visitation during that first day of treatment for patients because we know that can be very overwhelming. And if we anticipate going over any test results that would require a change in your plan of care or treatment decisions, we would want a support person to be with you during that time as well. We continue to try to leverage technology. As Kevin mentioned, we do utilize telehealth, and also when you physically come in for your appointments, we also encourage you to use your phones to call in your support and your family members that they can engage in your care delivery. I know it's not ideal as them being with you, but we again want to encourage you to use technology to provide that support while you're here by yourselves with our care team. I also wanted to take this opportunity to let you know how our staff have been doing in our regards to get vaccinated. I'm very proud to say that 83% of our Smilow staff have been vaccinated. I just think that's tremendous commitment by our team to try to, again, ensure the safest environment for your care. And I'm hoping that you see that we are doing everything we can to provide that safe environment for you. Also, there's many of you on this call that may have received an invitation to take part in a survey. So I'm just so glad that we're here this evening, because I'm able to personally thank you for completing that survey. We sent out a survey to almost 7,000 Smilow patients, and 700 patients replied to the survey, which I know that doesn't seem a lot when you think we sent it out to 6,000. But for me, we have 700 voices that have shared their thoughts and ideas on how we can improve our care. We asked many questions as far as the telehealth that we have been doing during COVID. Would you like that to continue? In what ways would you want a telehealth visit? We've also asked questions that our patients have replied to about whether you would like to see your physician or receive infusion services or other types of tests or procedures during non-traditional hours. Basically, we generally are open Monday through Friday, 8 to 5, but would you like to come in on a Saturday, or would you like to have an evening visit? So we're really taking all of that feedback as we continue to improve our access to care. And I just want to thank you for sharing your voice and letting us know what would be beneficial to you in delivering care. And so with that, I'm going to just turn it back over to Kevin for the rest of our program. And I'm just really grateful to be here this evening. Looking forward to answering all of the questions.
Thank you, Kim. So I think what I'd like to do is just start by reiterating a few key points related to the vaccination rollout. And I think that this has been one of the things that has challenged us as clinical care providers for our cancer patients, but we're also aware that the vaccination rollout in the state of Connecticut has been in some ways challenging for our patients and families. Under the direction of Governor Ned Lamont and our state leaders, the state government in Connecticut has elected to proceed with an age-based rollout of the COVID-19 vaccinations. And at this time, the state has approved access to the vaccine for people 55 and over. And eligibility really is determined by the state. And unfortunately, expanded access to patients under the age of 55 has not yet been granted. I assure you that we here at Smilow and throughout the health system are going to continue to monitor this, and we will update you and your families as soon as any additional access is available. The vaccination is widely recommended both for patients with cancer and for cancer survivors. So if you receive no other message from all of us this evening, we would recommend that if you are 55 and over, please log into MyChart and access the COVID-19 scheduling portal, or go to www.ynhhs.org, where you will find a landing page and a clear access portal for the COVID vaccination. You can also access Yale New Haven Health System through 1-883-ASK-YNHH. We will get into some more specifics related to both solid tumors as well as patients who have been treated with bone marrow transplant and stem cell transplant here shortly. But I want to take a minute to address what is a concern at the forefront of many of our patients' minds about vaccination access. The reality is that as cancer patients and survivors, we are aware that you are all a vulnerable population. And we have been in contact with state leadership about working with them to create enhanced access for our patients. At this point, it does not seem to be logistically feasible, but I can assure our community that this is something that we are in close dialogue with our state healthcare leaders about. And they assure us that they are rolling out vaccination as quickly as they can through the age-based protocol, and the increased vaccine availability with the recent approval of the Johnson & Johnson product will increase the access and timetable on the rollout. I think one other point that it is critical to underscore is that there are 3 vaccine products available. I think as people know, there's a product that has been produced by Moderna, one by Pfizer-BioNTech, and the more recently approved Johnson & Johnson, which on the package insert sometimes actually says it's a Janssen product, but it is really still a Johnson & Johnson vaccine. I cannot emphasize enough that all of the vaccines have been thoroughly tested. They are safe and they are efficacious. They have been tested in slightly different populations. The Johnson & Johnson vaccine is a 1-dose vaccine that does work through a slightly different biological mechanism, using an adenovirus, which is killed. It is not a live vaccine. There is no chance of getting a viral infection from this vaccine. And in fact, the Johnson & Johnson vaccine has been tested in patient populations in which some of these variants that we are now facing across the United States were present when the vaccine was tested. So the real key is to get the vaccination, regardless of the type. And I would urge all of our patients and family members to take advantage of any opportunity, any access opportunity, regardless of what vaccine product is available. It is really getting the vaccine in your arm that's critical, not the specific product. And we'll certainly take more questions about those vaccination products as we go along. So with that as a general background, I think I'm going to turn to Dr. Adelson next. And Kerin, maybe you could speak to our community about vaccination in our solid tumor population, particularly timing and the relationship of mammography to vaccination, vaccination in the survivorship period. All of those things I know are of concern to folks.
Great. I have a few slides, so I'm going to share my screen. Welcome, everybody, and thank you for the opportunity to speak about vaccines in our solid tumor population. So all of the recommendations that I'm going to share come from guidelines from a very important national organization called the National Cancer Care Network, or the NCCN. And a team of oncologists and hematologists and infectious disease doctors from around the country have worked to develop these consensus guidelines. And Dr. Seropian will also be sharing details in relation to the hematology population. So I'm going to focus a little bit on some of the recommendations for patients with solid tumors, with the exceptions of solid tumor patients who are undergoing any CAR T-cell therapy, which is going to be more appropriately addressed in Dr. Seropian's section, and that is a small population. So the first thing is that because this Connecticut rollout is done solely by age, which, I think Dr. Billingsley addressed this, and I think many patients with cancer and patients with other illnesses and comorbidities, I think, felt very disappointed that they were not put in the highest priority group. I think the good side to this is that the state is moving quickly through the age-based vaccine groups, and every 3 weeks, the group vaccinated becomes 10 years younger. So for patients with solid tumor, we just recommend that you get the vaccine in the highest priority group in which you fall. So as soon as your age is called up, we recommend that you go and get the vaccines. Dr. Billingsley mentioned this, but all three, Pfizer, Moderna, and Johnson & Johnson, are safe and highly effective. And then in terms of solid tumor patients, we really don't know, and there's been no studies looking at when getting the vaccine in regards to your treatment cycle or the day of your chemotherapy administration would yield the best response. And so the guidelines all really say, just get the vaccine as soon as it's available. And that holds for patients, whether they're on weekly therapy or every 2-week therapy or every 3-week therapy, or whether they're being treated with traditional chemotherapy or targeted therapy or immunotherapy. So we really just want the vaccine to be available and that you get it. It is important to know that if you are on immunosuppressive therapy, you may have less of an immune response to the vaccine. So while we know it's safe for you to get it, we are not entirely sure whether the vaccine of somebody who is immunosuppressed will be as effective as in the general population. And the studies have not looked at this yet. So it's really important that you continue precautions like social distancing, mask wearing, and hand sanitizing, even after you receive the vaccine. That aside, we really believe that most of the therapies we give in solid tumor affect the immune system in a different way than the immune system needs to be activated to respond to a vaccine. And we really do believe it will be tremendously helpful at preventing COVID-related complications in the population of patients on cancer treatment. We also, of course, recommend the vaccine for any cancer survivors and patients who no longer have active cancer, and for patients who are on hormonal therapies as well. And we do recommend that caregivers and household contacts get immunized as well. But again, that depends on where they fall within their individual statewide priority group, essentially based on age. So there has been a lot of hype and discussion. You know what, I realized I should have put this in slide view. Let me do that. One sec. Mike, okay. There has been a fair amount of publicity about patients getting imaging studies done soon after their vaccine and having swollen lymph nodes under the arm or in the axilla where the vaccine had been, in the arm in which the vaccine had been administered. So I think it can be very scary to cancer patients to have an enlarged lymph node, but just know that lymph nodes in the time period really after vaccine administration, it's just a sign that the lymph node is, that the vaccine is doing its job and it's generating an immune response and a proliferation of lymphocytes, which can be felt in the lymph node. And so this is normal. And if anything, it's a sign that the vaccine is working. So based on this, though, and this phenomena, which we're seeing in about 16%, certainly of women who get mammograms after the vaccine, we do recommend that you wait 4 to 6 weeks after your vaccine to get an imaging study, or as long as your oncologist and surgeon feels it won't negatively impact your treatment. And so we've seen these nodes not just on breast imaging studies, but we've seen them on PET scans and CT scans and ultrasounds as well. And so to just minimize confusion, if you do have a history of cancer on one side of your upper body, particularly a breast cancer, we recommend that you get the vaccine on the other side, just to minimize fear and confusion. And then for the patients where they do identify these enlarged lymph nodes in the period after immunization, the radiologists are just recommending relatively short-term follow-up to repeat the imaging and to hold off on doing many potentially unnecessary biopsies. So that is it for my subject. Kevin, do you want to announce who's next in the agenda?
Yes, Kerin, thank you very much. That was a terrific overview. You know, I think that one of the most complicated situations arises in our patients who are immunosuppressed or have had bone marrow transplant, stem cell therapy, or CAR T therapy. And what we have learned is that the timing of the vaccine is complicated in this group of individuals. At this point, I think I'm going to ask Dr. Seropian to address those issues in that particular patient population, of which he knows so well.
Thanks, Kevin. Apologize, I don't have slides to show. And I know that not everyone on the call has had a stem cell transplant or CAR T therapy. My comments are really going to be very specific to a small group of patients that are, as Kevin mentioned, a little bit different in this regard. But I'll start by making the general comment that all of the patients who've undergone these therapies should get vaccinated at some point. We still think it's quite important. Patients who have these therapies are really very vulnerable. And we also encourage all of their family members who are eligible to get vaccinated as soon as they can. And the only thing that's really different about this patient population is that we've known for decades that vaccines are often less effective in patients who undergo these therapies if they're not given at an appropriate time when there has been some chance for the immune system to recover from those treatments. The guidelines for this that have been set forward by the transplant societies and the American Society of Hematology encourage all patients to get vaccinated. However, the guidelines suggest that the earliest this should be pursued is 3 months after a transplant or CAR T therapy. And there is not specific guidance for exactly when after these treatments vaccination should be initiated because all patients really are different in terms of their clinical course and variations on their treatment and the tempo with which their immune system recovers. There clearly are patients for which we have good data for all vaccines that conditions may prove that the vaccine will provide no response. These include people less than 3 months after transplant or patients who are on high doses of immunosuppressive agents. And in many cases, we can make adjustments to people's treatment to enhance the chances of successful vaccination. I do get asked, well, isn't getting vaccinated, even if we think it won't work, better than nothing? Well, the long answer is yes, we want everyone to be vaccinated, but we don't have an unlimited supply of vaccine. And a patient that we vaccinate at an inappropriate time may not have an opportunity to be vaccinated within the next year at a time when we can have at least a reasonable chance of success. I would say that more than 3/4 of patients who've undergone these procedures really are not going to need to wait to get vaccinated. The advice will be they just get vaccinated as soon as possible. And we are fielding phone calls and clinical visits to try and get these answers to our patients as quickly as we can. There will be a small group of patients where adjustments in medication or blood testing to examine immune function will help us to determine the appropriate timing of response. Apologize, the phone's ringing in the house. Many of you who've undergone these procedures received a letter from us urging you to reach out to your transplant provider or your other providers who we can also speak to, really just to discuss the issue of the advisability of the timing of the vaccine. If you didn't get that notification and you've had a transplant or had CAR T therapy, then I do encourage you to reach out to your providers. There may be people who had transplant more than 6 or 7 years ago that may not have received the mailing because they're that far out. But this really applies to everyone who's had these kinds of therapy. We're happy to give advice to anyone and everyone who's had these types of therapy to help guide them. Regarding the particular vaccines, safety-wise, although there is limited data so far in these patient populations, there is some experience and some data. This issue was recently reviewed at our yearly transplant society meetings. There has been no evidence that these vaccines are unsafe in patient populations such as transplant or CAR T recipients. So there is also no good medical or biological reason for us to consider that they would be unsafe in our patients. As Dr. Billingsley illustrated, the J&J product is not a live virus. It's incapable of replicating, and the Moderna and the Pfizer vaccines are not viruses at all. Their proteins stimulate an immune response to the virus. So they appear to be very safe. And currently there is no good efficacy data to push us towards one or the other vaccine. So we will be talking individually with all our patients about what we think the best route to get a vaccine as quickly as possible would be. And there may be shortages that arise intermittently. So we encourage people to choose what is most readily available when they try to schedule vaccine.
Dr. Seropian, thank you for that really great overview. And I do appreciate you taking our audience back again through the very important biology of these vaccines, just to underscore that they have different mechanisms, but the thing that unites them is that they are all safe. There is no live biologic product that is injected in any of these vaccinations. So Tara, Dr. Sanft, maybe we could turn to you for a minute. I see you had your partner on board. She may have
partner in crime.
But you know, there's no doubt that we have all weathered really a stressful period in our personal and professional lives, difficult for families, and these things take a toll on us as individuals, and particularly when we are caring for a friend, family, loved one who may be battling cancer as well as trying to navigate life in a pandemic. You coordinate many of our supportive services. Can you update our audience on special services that they may want to avail themselves of? Where do we stand with those things? How accessible are they? And any particular recommendations from your standpoint?
Yeah, thanks, Kevin. I think it's just a really nice time to reflect back about a year ago and to look at where we were and where we are now. And to thank everyone for sticking with our community here. You know, I think that we're here in this together, and we stuck together as a team. And I love that we have these forums where we can communicate with each other. And that's one thing that came out of this pandemic that I think is here to stay in terms of improved communication. But in terms of how each individual is doing or coping, you know, certainly anxiety levels have never been higher. In order to comfort ourselves, we're often going to the extreme of too much that we find comforting. So we're either numbing with too much Netflix or screen time or sedentary time or cheese and crackers. And so for some people, it's too much things like alcohol. And I think that that's true for any individual who feels anxiety or fear. It's normal. But if you're someone who needs some help with all of that, we certainly have many, many resources to support you and your loved ones and anyone who's going through a difficult time during this pandemic. I do have a slide just to remind people that we have support groups here. Our support groups went online once the pandemic hit, and I think that just today, one of my patients in clinic said how helpful this was to her. We've even had COVID-related support groups as well. The integrative medicine team has done an amazing job of coordinating so many supportive services that are all virtual. And I'd like to put a plug in for the integrative consult service, which talks about all different ways to comfort ourselves in healthy ways, either as you're going through cancer treatment or supporting someone who is. And then of course, the palliative care and survivorship services continue both inpatient, outpatient, in-person, and virtual. This is just an example of the integrative medicine weekly events. This is from January, but I assure you that every week they are updated. I just printed one out for my patient today. And there's all types of ways to connect, to receive meditation, and to participate in movement, even though you may still be feeling restricted to your home. We're here for you as a community. We thank you for your wonderful support and words of gratitude. Every time you write something nice, that you say thank you, you say something nice to us, it really does impact us in a really powerful way. And so thank you for all of that. We're here. Reach out with any questions, concerns, needs, or words of gratitude, because we always appreciate when we feel connected to you. And I'll stop talking there.
Tara, thank you. I think it's hard to overstate the importance of self-care for all of us and taking advantage of the resources that we have available. You know, I think without any further commentary, there are a lot of really great questions coming forth in the Q&A, and I have some here that Renee prepared for us. And I think we should just jump right into it. We're here to be available to answer your questions. And I'm just going to start with one for Dr. Adelson. I think you kind of touched on this, but this just to revisit it, this individual is asking, I am scheduled to get my second dose this week, March 10th, and have a mammogram scheduled for the following week. Should I try to reschedule my mammogram to make sure that there are no false positives on that side of my body?
So if it's fine with your doctors, we would recommend delaying your mammogram by 4 to 6 weeks. I would say that there is a backlog in mammography due to the first wave of COVID and a slowdown of radiographic imaging studies. So I would call and make sure that you're able to reschedule it and to let them know why. But we would recommend that you wait and that you get your vaccine and then you wait to get the mammogram.
Thank you, Kerin. You know, I may take this one, but I'll ask anyone to chime in. And this is from the question and answer box. This person says, we had our second Pfizer vaccine on Monday, but we still have intermittent fever, fatigue, and sluggish thinking. Is this normal? Might it persist? And, you know, what I would say to that is that we have seen an entire spectrum of post-vaccine reactions. Fortunately, the vast majority of them are annoyances and are mild and self-limited. It is not uncommon for these symptoms of fever, malaise, even body aches, sometimes poor appetite, to last for several days after vaccination. I think it's perfectly fine to treat them with anti-inflammatories, rest, fluids, common sense. And I'm not hearing anything here that is concerning. I have tended to remind people that we actually, it's not bad to see some inflammatory response. It means that our bodies are doing what they should be in response to these vaccines. Do any of the other clinicians on our panel have anything to add to that?
Just like you said, Kevin, there is a full range of responses, and some people really can feel pretty sick for, you know, a week at a time. Some will even have some responses that go out longer, but that's not the norm, but it's absolutely normal. That makes sense.
Yeah, thank you. There's another one in the Q&A that I think is important that, Stuart, I think you can provide some insight on. This individual asks, what are the vaccination recommendations for traditional blood cancer patients not on path for stem cell transplant and or CAR T?
So I think it is a good idea for patients who are on treatment to discuss the vaccine timing with their physicians, just with regard to review of any medicines that are being received that might blunt the response to the vaccine. The American Society of Hematology guidelines do suggest at least consideration of an adjustment of the schedule for treatment if it's feasible. But just like in most of the solid tumor patients, getting vaccinated is better than not getting vaccinated, and adjusting treatment isn't always advisable. So this would be a situation where patients should reach out to their provider. Just for the general information of the audience, the medication that is most likely to blunt response to the vaccine are steroids. So these are medicines like prednisone and dexamethasone, and these are used frequently in the treatment of blood cancers. So they may be used in some solid tumors, but they're quite common in the treatment of multiple myeloma, non-Hodgkin's lymphoma, in some types of leukemia. And sometimes this may be an issue of skipping a week of a steroid medicine or reducing the dose temporarily in the 2 weeks after the first dose of the vaccine. So that is considered. So this has been discussed in the hematology section. The faculty are aware of this option. And of course, patients who are on treatment are being seen frequently, so they can discuss this with their providers. There are other agents, such as the monoclonal antibodies, like rituximab. These are medicines that reduce the function and the quality of our lymphocytes that make antibodies. They're very effective treatments for lymphomas, and they may also blunt the response to the vaccine. So patients who receive these drugs, again, should be talking to their providers. In most cases, they should just get the vaccine, and we will consider that it's better to get it, even if it might be less effective. So, and just to reiterate, and I think you already mentioned this, in these patient populations, receiving the vaccine does not allow us to dispense with our social distancing, our masking, our avoiding exposure of ill patients. We really still need to be careful, even after getting vaccinated.
Thank you. And, you know, on that last piece, I think there are some questions about that I think it's worth taking up. And any of the clinicians can jump in on this. There was a particularly poignant question here that I think we should do our best to address. This individual asks, is it now safe, I assume after vaccination, to go visit and hug our grandchildren after our second vaccination while masked?
Kevin, maybe I can address that. I'd be interested to hear what other people say, but I am a member of the Smilow or the Yale New Haven committee that is addressing vaccination issues in immunocompromised patients. So that includes a lot of the patients who are on this call, clearly. And this was discussed just last night based on an article that came out in the New York Times. A lot of people saw in regard to the CDC's recommendation that this might be okay for grandparents to be getting together with grandkids in houses where they've been vaccinated. There is still a lot of concern and uncertainty about the asymptomatic carriage of the virus, even in patients who've been vaccinated. And while the data suggests that getting vaccinated reduces the likelihood of carrying the virus around if you were to be exposed, it doesn't eliminate it entirely. So I can just report that the infectious disease experts that we work with are still concerned about letting our guard down in the midst of the vaccination rollout when it's only 17% of the state, less than that around the country, have been vaccinated. So I think the official word that's going to come from our committee is to stay tuned and keep social distancing and wearing your mask. It doesn't mean you can't see family members, particularly if everyone's been vaccinated and people are being safe. But I think we still need to be careful.
So
Go ahead, Kerin.
So I just want to sort of say that we are all walking a really hard line right now between doing what is safest and desperately needing to live our lives and see our loved ones. And sometimes there's not a clear right and wrong answer. I will say that for the older population who have just less time left to live, and for patients who have advanced and metastatic cancer, this year has been incredibly painful because it has felt like you are losing time and you don't have a lot of time. And I think that in all of our decisions, we need to balance safety and emotional well-being. And the answer may not be the same for everybody. And you know, we just ask you to be thoughtful and be as safe as possible, but recognize that it may be really important to see your grandchildren.
Kerin, thank you for that really thoughtful reflection. I think that that captures beautifully what we're all working hard to manage. One person asks, actually says and then asks, I am most comfortable being administered vaccine through my Smilow care team as they best know me and my treatment plan. Will this be an option? Kim, do you want to maybe give a start with that one, and any of our other panelists might pick up on that as well?
Sure. Yeah, I can we would love to be able to have enough vaccine supply to be able to vaccinate our cancer patients in our clinic. But really, with the best way we can vaccinate all people in the state of Connecticut is through our mass vaccination process. There's so many operational challenges with the storage and the way we need to keep the vaccine. We want to use every single dose that we get available to us in the state of Connecticut. And our vaccination sites have been very efficient and effective in administering as many doses as we receive. Actually, our state, I wish I knew the actual statistic now, but our state has been very, very successful in getting what we call vaccine into the arms of our residents. So right now we are just really focusing on those mass vaccination sites because that's where we can get everyone vaccinated as soon as absolutely possible. So that gets evaluated all the time based on the supply that our state gets. So I just want this community to know that our organization is always looking at this, and we are making decisions based on the supply that we get and how we can get it to all of our patients as soon as possible. So right now, the answer is we won't be providing it in our Smilow sites. And we are really encouraging all of our patients to go through the mass vaccination sites, but it is something we evaluate on a continuous basis, depending on supply. And I don't know if anybody has any additional comments.
Kim, I think that was incredibly comprehensive, and you do so eloquently speak to our what I can best describe as our ambivalence about this. We as oncology clinicians really, in an ideal world, would deliver comprehensive services to our patients, but we do balance that against the larger public health mission that the state has outlined and that we want to be in collaboration and compliance with. And I think, I will use that as an opportunity to bring forward a related question that one individual asks, and I think is on the mind of many of our patients and families. And the question that I'm specifically looking at reads as such: any insight as to why cancer patients and people with illnesses were taken out of the vaccine rollout? Our group was supposed to be in line, now it's by age only. Well, again, very difficult situation for us as oncologists. We do feel like we care for the most vulnerable patients and they should be first in line. That being said, decision-making amongst individuals who have any range of complicating underlying illnesses or comorbidities, including autoimmune diseases, cardiac diseases, obesity, chronic pulmonary disease, hypertension, various medications, all put people at some increased risk in addition to people who are on cancer treatment or recovering from cancer treatment. So I think creating an equitable framework in which people with comorbidities would be prioritized versus age is and would be a daunting task. And I think that as much as we struggle with this, our colleagues in the state health department are understandably pursuing a path that likely will get the most vaccine in the most people in the most efficacious way in the current rollout strategy. In the meantime, I think our biggest obligation is to stay vigilant, stay safe, and continue diligently with social distancing and mask wearing and thoughtful practices about where we are and what we're doing. Anything to add to that commentary from my colleagues?
I think I just want to acknowledge how frustrating it is for people. And, there is one comment in the chat from somebody who is young, but has a stage 3 breast cancer, and her younger sister, who's healthy, got a vaccination before she did because she works as a teacher or she works in the education system. And there is a profound feeling of unfairness. And I think there are so many groups of people who feel like this current rollout is leaving them out or delaying them or putting them at risk. And I think it's just so hard to get it right. And I think what the governor picked was something that was simple and that he could move fast so that ultimately everybody, even the younger adults, will be able to get their vaccine in a relatively short time period. So I think no matter how you approach it, there are people who will feel left out and who actually will be left out, but I promise that everybody will be gotten to in the near future.
You know, one of the questions, thank you, Kerin, one of the questions that is coming forward from a variety of folks is there a role for antibody testing if people have been on any kind of treatment to assess vaccine response? And I guess that I will say there is no defined role for antibody testing after vaccination. But Dr. Seropian, do you want to weigh in on that too?
Yeah, I would just qualify that to say there's currently no defined role, but this is being studied. It will continue to be studied. We have plans to study vaccine responses, not just antibody, but there are other immunologic tests to assess other parts of the immune system that are important. We'll be studying this in the transplant patients, and the group that is considering issues around vaccination immunocompromised patients has taken this up to review the issue. And it just for people's general knowledge, because it may seem straightforward to say, well, I had the vaccine. If I have an antibody test that's positive, it worked, right? Yeah, unfortunately, that's not clearly the case. It's far more complicated. The available antibody tests that are on the market now have not really been qualified to prove immunity to COVID. And not only are they not really qualified to prove that people have protection, there's very little information on the durability of these antibodies. Many of the commercially available tests are different from each other. Many of them don't give us quantitative analysis of the magnitude of the antibody response. So in other words, someone could have a positive test of a small amount of a weak antibody to the virus that isn't very meaningful. So this is an area of study. It's particularly important for populations like our cancer patients because they may not respond well. So I would and have been encouraging all of the patients I see in the transplant program to discuss with me donating research samples so we can try and figure this out. And if people hear of other studies that can participate, that certainly is encouraged. But there will be more information on this. So I think probably later in the year, many of the patients on this call who have been vaccinated may have the opportunity to get a test to see whether it worked well. I think I would discourage people from spending their money on commercially available tests because they heard another patient went and did this, because the tests haven't really been validated in a way that we can use them sensibly to advise people. There's more to come on this, and I think we will be doing it in the future, but we're not quite ready yet.
Thank you. I think that's really helpful. As the surgeon on the group, I do want to take up kind of a broad-based answer to a few questions that I've seen. One is a question from a woman who has had bilateral mastectomies and lymph node surgery in both axilla, both armpits. And her question is, should she receive the vaccine someplace else in her body? You know, I think that is concerning, but overall extremely safe. The risk of developing lymphedema after one of these vaccinations is remote. You know, quite appropriately, if you do have axillary lymph nodes, there may be some reaction, but there's a very, very low likelihood of developing cellulitis at the injection site, which would cause lymphedema. What about other operations? In general, the primary reason for avoiding vaccination in the postoperative period is so that symptoms such as fever can be correctly attributed to the surgery versus the vaccination. So we would not encourage you to have your vaccination and then have your surgery a day or two later. Our general guideline is about 2 weeks. It may be a little bit longer if you're having a complex operation like splenectomy. And it was probably best to wait a few weeks after a complex operation, such as an abdominal procedure, before having vaccination. But in general, we are encouraging people to proceed with vaccination in a timely way. You know, I think I want to be mindful of the hour. I hope we have answered the vast majority of our community's questions. And I'd just like to give our panelists an opportunity to share any last thoughts with our patients and families.
So Kevin, thank you. I'll just say real quick that I want to thank everyone for joining us tonight. As many of our panelists have said, you know, we just want to make sure that we are doing everything to help you and your loved ones stay safe as we continue down this path together. And we're here with you every step of the way, and we're here to answer your questions. If there were questions that we did not answer tonight, we will follow up, and we will continue to have these forums. But you know, we encourage our patients that when you can get the vaccine, to get vaccinated, and that still continue though with all the other safety precautions as well. And we are doing the same here. We are getting vaccinated. We are social distancing. We are wearing our masks. We are washing our hands, and you know, we're just here to go through this with you.
Thank you, Kim.
Kevin, if I can give a really quick answer to a couple of questions I saw that I thought should not be left unanswered tonight.
Thank you, Stuart.
There were a few questions from patients who have histories of anaphylaxis. It wasn't specified exactly what they were anaphylactic to, but this is one of the few potential contraindications to getting the vaccine that's quite important. So people who have anaphylaxis need to contact their doctor, and it may be advisable to consult either with an immunologist or an infectious disease specialist, because it may not be safe. So I didn't see the details of those people who asked about what they were allergic to, but it's clearly anaphylaxis to other vaccines. But there are other medicines, including components of some chemotherapy drugs, that can cross-react with the vaccine. So if someone's had anaphylaxis to anything, if they go and sign up for the vaccine, they might be rejected when they show up because of that history. They need to talk to their doctor first.
That's a really important point. And I do think that this is one of these things that is so variable that it is difficult to answer that question in chat format. A clinician really needs to know what the details of your history and reaction are.
Maybe we can say, when in doubt, reach out.
I think that's perfect. And on that note, we wish all of our patients and their families continued safety, and we hope to see you soon. Have a good evening.